Well, hello, wonderful Brainstorms audience, and welcome to our last podcast of 2025. We really appreciate you sticking with us this year. We promise 2026 will be just as informative and just as exciting for all of you who are dealing with issues related to brain health, who are finding solutions. And that's what we're hoping for today as well. We are brought to you here in the wonderful Sycamore Studios, Plain City, Ohio, with our great both founder and the best editor, Steve Musa, who gets the information to you in a way that is both enjoyable and informative. And again, we thank the Fred and June McMurray Foundation for helping us get through this, and they have just taken us on for another year. So we will be seeing you in 2026. So today, our final episode in December is part 2 of the S.T.R.I.V.E to Survive the Holidays, which I think our current guest, who is actually the director of the S.T.R.I.V.E program at the Ohio State University, will tell us how to thrive during the holidays, which is even better. I can't tell you how excited I am to have him here in our studio. He is both a military member and a psychologist in the civilian world as well as the military world. He served in the U.S. Navy, is now in the U.S. Naval Reserves, and is director of the S.T.R.I.V.E program, and he's going to tell us all about that and all about kind of a follow-up to his colleague, Dr. Kazim's story, which was how to kind of de-escalate certain situations around the holiday table that can get stressful. He's going to tell us if those things don't work, or if you do have issues, how to face them, how to cope with them, and how to bring your friends in to help. So without further, I'm just so excited to have you here, Dr. Justin Baker, and also U.S. Naval man, Dr. Justin Baker. Thank you for joining us.
No, I appreciate it. Glad to be here. Happy to be sharing our work with you and the audience.
Well, it's phenomenal. And as I was going through your bio, which I know hasn't been updated, I mean, your accomplishments in your young life in the military alone, I mean, for our audience that may or may not know about the Naval Marine connection,
Sure.
We've been talking, explain that just a little bit, because you got commendations in both, so.
Yeah, no, I did all of my schooling in Southern California, and while I was looking at my internship placements, I wanted to go with the VA. Okay. And it was really when I was working at the Veterans Affairs Administration as a clinical psychologist that I started wondering, how can I help veterans more? So a lot of the work that I was doing there really I started seeing like, gosh, if I could just work with these veterans sooner, I could save a lot of heartache. So that's when I decided to join the military.
Oh, wow.
So I joined as a postdoctoral fellow.
Okay.
That was back in, maybe 2014, 2015, somewhere in there. And then, so the Navy provides all the medical service for the Marine Corps.
Okay.
The Marines don't like to hear this, but they're technically a department of the Navy.
Right.
But we've worked together, the Navy and the Marine Corps have worked together historically for years. The tradition is the Navy sailed the ships, the Marines rode on the ships that, took them places to fight wars. Yeah. And so while they were on the ships, they got medical care. So that's the relationship. And so, I was able to finished my postdoc at Naval Medical Center Portsmouth, and then I was stationed at Naval Medical Center Camp Lejeune in North Carolina.
Which is the Marine base on the East Coast, right?
Yep,
okay.
It's one of the largest Marine bases, definitely in the country, maybe possibly the world. It sort of mirrors Camp Pendleton, which is on the West Coast. And so while I was there, I worked as a naval psychologist in the hospital, but also I was detached with the Wounded Warrior Battalion, which is a battalion specific to caring for the ill and injured from the current conflicts.
And that, the signature wound, brings us right into the traumatic brain injury,
TBI,
post-traumatic stress syndrome. Okay,
all of the above, yeah.
I just have to pause a moment and let our audience bring that in, that this is somebody who saw the issue and said, if I'm going to really know it, I'm going to join, I'm going to help solve it from the inside. And that is amazing, and we thank you for that. And then how long did you serve in active duty then?
So I was an active duty psychologist in North Carolina until 2018.
Okay.
I wasn't quite ready to get out, so I transitioned to the reserves.
All right.
And while I was active duty, I started looking at the state of the evidence and how we provided care.
Okay.
I started making connections with university professors to improve the quality of treatments that we offered to the Marines.
I gotcha.
I wasn't quite satisfied with the status quo, and I was like, we could do better.
Oh, how wonderful. Yes.
And so then that's partly what led me to get out, because at that point I felt I could have the biggest impact on the outside,
Right.
but still working for the Marine Corps, the Navy, Air Force, Army.
Right, exactly.
And so I got out in 2018. That's when my bio, I think, sort of starts what you pulled off the website.
Right,
So
right.
I got a job at the University of Utah, working with Dr. Craig Bryan.
Yes.
Preeminent suicidologist, has been doing this a lot longer than I have. A lot of the treatments we'll talk about today
Yes.
are from his work, and just found myself really well connected with a team that could really harness how do we help veterans, active duty service members struggling with suicide to really significantly reduce that risk.
That is amazing. You've done research on your own in
Correct.
that order, too. I'm really interested, if you wouldn't mind explaining a little bit about your text. I mean, I
Sure,
thought
yeah.
that because, being a couple generations removed from you, when I started working with young veterans, very young veterans from Iraq and Afghanistan, I did not text. And I realized I had to learn really quickly, so.
Yeah, the caring contact study that you're referring to, which is a text message based, like sort of
Which is
caring
amazing.
note, right?
Okay.
That was actually done while I was still active duty, before even getting out.
Oh, really?
So I worked with Dr. Catherine Comtois, who's at the University of Washington.
Okay.
And the work that she took actually adapted a really old, not really old, but an older intervention, I'll say, from about the 70s, from
Okay.
Jerome Motto, who also, definitely a veteran. I don't remember which branch, I think Army. But
Okay.
he was, I believe, an Army psychiatrist. And when he got out, when he was in, I think it was World War II, he received like these letters from his hometown, and he realized how much just those simple letters
Yes.
got him through the conflicts that he was facing.
Yeah.
So he applied that, now a psychiatrist, I believe studying in the California area, maybe San Francisco, applied that same logic to the patients he was working with and just sent them simple reminders via postcards, hey, I'm thinking of you,
Oh, whoa.
right?
Okay.
And it's one of the few studies still to date to demonstrate reduced deaths via suicide, not just ideations or attempts.
Well, that's something to remember when we're going through the holidays. You can wish them a holiday message that is very personal,
It's a non-demanding, just,
Yes.
hey, I'm thinking of you. You don't expect anything in return, just
Okay.
to know that you're not alone is really the key
That is
component.
amazing. And you did that at quite a young age yourself, so
I mean, most of it is Dr. Comto's work, so I don't want to, steal
I
the show.
understand that, right? I understand, but I'm also sure he doesn't mind passing it
Yeah.
down to the generation that's actually dealing with it now,
Correct.
in real time. And you are of the informational generation, getting things via your smartphone. I was amazed, when we started out. Before our foundation was a foundation, we actually did a documentary called Operation Resurrection. I like the term resurrected because I had my own brain injury, and it was like a death and resurrection. It was not like I just went out. It was like everything I knew about me was gone.
Changed,
So
yeah.
it was that. So we did Operation Resurrection. We were out in the Santa Monica. The largest group of homeless veterans is between L.A. and San Diego.
Yeah.
So we were kind of right in between. And every single one of our young vets from the Global War on Terror had a smartphone. Like
Sure.
they didn't have anything else. They had
their phone,
and,
yeah.
And that's when I said, this is a lifeline, right? And that's what you're talking about using it as.
Yeah, so we adapted that original work from the 70s to the 20th century, just using text messages
Yes.
to active duty Marines, and saw a tremendous benefit,
Oh.
right? And we're actually continuing work since you mentioned homeless
Please do,
populations.
yes.
And how to engage homeless populations, still with Dr. Comtois, using people's smartphones, right?
Right.
So it's not easy for someone to always come into treatment, but can we bring the treatment
And we can.
to them, right, via their smartphone?
Exactly. I am a firm believer, only because, again, we have offices, as I told you. Our base is here in Dublin, Ohio, Plain City area, and our ancillary office is on the West Coast in San Diego. And I do recall, and we can talk about this later, and this sounds like a good podcast for next year, but
Yeah.
literally a group of veterans who were on a block, homeless in San Diego. One got COVID, the second got COVID, and they called me, and I'm there like, well, okay, here's what we're going to do. The closest CVS. And what I did is I got the youngest person because the pharmacist said, oh, I'm not going to deliver anything. I got the youngest kid on the who delivers this stuff. And he delivered, what they needed, the pulse oximeters and the thermometers. And one of the people needed to have antibiotics. And I did have my California license. So, I mean, literally a block was very easily by that, So I think that's genius. I want you to carry that on. I'm like the old guy in San Francisco, older guy in San Francisco, carry that on. That's amazing.
And we want everyone to receive treatments, not just those who can pay for it. We want those who need it to get it. And so we're trying to think in ways to make it more accessible.
Exactly. I thought that was brilliant when I saw that. And you can go on about what other research you want to, and then we'll get to but I just wanted the audience to get to know you a little better too.
Yeah. So I was in, just to continue my bio, I was in Utah for 2 years. Mm-hmm. I was still a reservist then, and I was actually deployed during COVID.
Oh, really?
I thought I was going to make it all the way out to Guam, but instead I only made it as far as San Diego.
Oh, okay.
But ended up just working in a naval hospital out there in the desert. 29 Palms, if people are familiar.
Yes. It has a reputation of being very difficult.
It's not an easy. I mean, it mirrors what they see in Iraq and Afghanistan, which is the intentional component of that base. So I worked there for a few months. And then my family actually and I, with Dr. Craig Bryant, got the opportunity to come here to Ohio State. Yes. And so we've been here continuing our work ever since.
Yeah, it is amazing. And I had actually called him because he helped our foundation when I decided that I think I explained to you, and I've explained to the audience before too, that we're not a crisis intervention place at all. But if you're going to take this on, there are crises that arise, and you better be, ready to deal with them. So it was studying his class and what we'll talk about here, the crisis response plan, that we'll be talking about. And I know that you were involved in it too. So I called him. He goes, I'm leaving to go to Vermont.
He's following our mission to Vermont.
Exactly. So you're in charge here now. You are now maybe you were the director always of the S.T.R.I.V.E. program.
Clinical director that I came with that title, and now I'm stepping into the director role. Craig and I are still very much working together to advance the same mission. Right. Now we just get to do it from 2 universities.
And I will say this, that there is I introduced him via email to a phenomenal ER doc there, Dr. Caleb Freeman, who was one of the first very young ER physicians in New Hampshire there, in the New Hampshire area, then the Vermont area at the University of Vermont, and noted these young guys coming in back from war who work, and he started some of the initial ER studies and that. So that's going to be a great connection.
We're excited about we really see it as an expansion.
It is.
And
you're coming across the country. Right. You started in the other coast, and here you are already in it's 7 years. That's amazing.
Yeah, pretty good. Native Californian living in the Midwest. Right?
Yes, exactly.
Can't get better than that.
Yeah. So. I don't know how you deal with the winters, but good for you.
We strategically place vacations when they need
to. Do you really? I got you. That's part of our brain health, right? That's our mental health, for sure. Right. So we're talking about the holidays now. And again, as I had mentioned when I was talking to Dr. Kazem in the last podcast, the amount of loss that our veterans have compared to civilians, and I know there's civilians who've had a magnitude of loss too, but I've never talked to 30-year-olds. And when I was 30, certainly I didn't know 3 of my colleagues who had perished, let alone 30, you know. It's a difficult time, right? You're supposed to be happy. Yeah. There's something wrong with you if you're not happy, right?
Sure.
Yeah. So what do you notice around that time?
Yeah, it is a difficult time. And I would say it's difficult for veterans year-round, not just around the holidays. Right? We know veterans experience trauma at higher rates than civilians. We also know veteran suicide rates are elevated over civilians. It's certainly not to not to address the civilians that are struggling. They certainly are as well. And these are stats that are pretty well known, but suicide-related deaths for active duty service members surpassed combat-related deaths in 2012. Right, and the rates have only continued to increase.
Almost 5 times, yes.
Right. For all young people, ages 18 to 24, suicide is the leading cause of death, or second leading cause of death, I should say. Okay. And so it's a very pervasive problem that sometimes can get exacerbated at different times of the year.
Yes.
Research is sort of uncertain if Christmas is one of those times. There's other research that shows that summer or June is another time. But regardless, Christmas, the holidays can be stressful.
Yeah.
Right?
Well, it is stressful to civilians,
Yeah.
I never see
We gotta
my family
get all
so
the
much
gifts,
as I
talk
see
to
them.
people we may not want to talk to, right? All the things, right?
And now with politics
Travel.
and chaos in the world, I
Yeah.
know
It's all the things.
it's become a lot more stressful as we read about,
And we
in
have
the
these
papers.
assumptions of how it should be.
That's
And then,
that's a
and
major
then it doesn't
problem.
maybe happen that way.
Right.
Or we now no longer have all those in our lives that we used to have.
Right.
So now Christmas or the holidays feels different, and it's not how it used to be when we were kids.
Right.
It's all of that,
Yeah.
all the complexity of that.
Yeah. So, in your experience in that, because I want to talk about what happens
Yeah.
when someone really is in crisis. How do you know? What would our listener who may not be a military member or veteran or their family, what do they do? What do family members do? Caregivers? What do friends do?
Sure.
When they're meeting together? I'll let you take it from there.
Yeah, so one of our interventions called the Crisis Response Plan, which we've already mentioned here, we started out, developing that for use in the clinic,
Yes.
right? Training licensed mental health providers. When you have a suicidal patient come in your clinic, what do you do, right? So the standard of care, back, at the time when we were developing this was, well, let's just give you a number to call when you're struggling. It turns out that that's helpful, but it's not enough, right? It misses the mark of addressing the pain and suffering that they're in right now, right? And so the crisis response plan is sort of broken up into two phases. First, it's just, hey, tell me your story of what's going on, so that I, as the provider, can understand the crisis you're experiencing.
Okay.
Whether it was a recent attempt, elevated thoughts of wanting to kill yourself, whatever that might be, I just want to have you tell me in your own words, however you want to organize it, what's going on.
That's wonderful.
That alone is extremely validating just to have someone listen.
Okay.
Right? Listen to something that may not be your best moment of your life, right?
Right.
Often it's one of your worst, right? But now you're not alone in that dark moment, right? And so just that we find can be extremely regulating. The sort of tension, the anxiety, stress starts to sort of peel away.
Okay.
But we don't stop there, right? Again, that's helpful, but we still need to address what can they now do
Okay,
if they
great.
find
Action. Okay, yeah.
What can they do if they find themselves in this situation again, or if they're still in that situation, whatever that crisis may be. So that's where the plan comes in. So this is the second part of that, right?
Okay.
So first we, tell me your story. Now let's develop an action plan. And this really pulls, Dr. Craig Ryan was also in the military. His predecessor before him, David Rudd, also in the military.
Yeah.
So we are pulling this sort of legacy experience of developing, well, the military has standard operating procedures, right? Or SOPs.
Right. SOPs, yes.
We follow those so that we know what to do without sort of even thinking. That's what this action plan is. It's 5 steps that helps us address the current pain and suffering that we're in, right? And so this was something that we developed with the patient, right?
Right.
It turns out, though, right, if we only kept this cool intervention, which we know works,
Right.
with mental health providers,
Yes.
we miss something like 75% of those who end up dying by suicide.
Okay.
So a lot of the work that Dr. Brian started, and I've now been continuing with him, is taking it out of just the mental health realm, and let's put it with peers. Let's train chaplains. Let's train police
chaplains,
officers.
yes,
Let's
yes.
train nurses, physicians. Let's train all the other people. So it's just up to the mental health providers to
Right.
solve the suicidal crisis. It's up to all of us.
It's really true. That's amazing. And that's just a recent mega jump that you made, right?
Yeah, it's we started one of the first. So Craig actually started a version of this back in 2009 when he was in Iraq.
Okay.
But we didn't start to study it until about 2020.
Okay.
Yeah, to see if it's efficacious or effective, right? And COVID sort of messed with our results there.
Yeah.
It's hard to increase social connection
Right.
during a time when everyone's like, stay away from everybody, right?
Right.
But we're running the study again.
Oh, good. Okay.
But the cool thing that came out of that 2020 study is we did it with Air Force. We saw airmen using this intervention that I just described
Okay.
with their peers, but they use it so far in front of the suicidal crisis. So like as the provider, I usually see them after.
Right, exactly, right?
They're like intervening right when their girlfriend or boyfriend breaks up with them.
Oh, so smart.
Suicide's not maybe even on the table,
Right.
But they're sort of changing the trajectory by just introducing this really simple intervention, which is really cool.
That is so amazing in the listening part, I think, because we are not as much of a listening society.
No, we're terrible at listening.
Yeah, exactly.
Most people, when they're listening, are just thinking about what they're going to say next, right? They're not actually listening.
Right.
Yeah, and so that's a big part of it is truly listening.
Yes.
Right?
Yes.
Like just tracking. Sort of imagine, when you are listening to like a 3-year-old, whether it's your kid or if you're an uncle, an aunt, right? And if you're listening to them, but you're also on your phone, they get the qualitative difference. But if you set the phone aside, maybe squat down so you're like eye to eye.
Yes.
That's the kind of listening that we're going for. It's like, hey, nothing else right now matters except what you're about to tell me. It's focused, it's engaged, it's empathic.
Very human.
It's connected.
Yes.
Yeah, that's what we're looking for when we're thinking about that kind of listening.
And that may be the one connection at that point in time that keeps them here. Exactly. That keeps them here. So you mentioned then that there's some things that you do with the plan. Could you explain a little bit about that plan? And then we can explain how they can get this course that I took online that was amazing. So
So we start with the listening, right?
Yes.
And then the plan part is quite simple. We use a note card, right? There's no forms or anything like that. We want something to write the plan on.
Okay.
Again, when someone is struggling with suicide, they're emotionally overwhelmed and they're sort of cognitively stuck. They can't, deal or manage the emotions.
Right.
And they can't think through a solution. So we don't want to have something that's hard to memorize or whatnot.
Very good point.
Hence the SOP, the plan. We write it on a note card. So all they have to do is pull out the card and just follow the steps. Right?
Very cool.
The only thing they have to memorize is that first step. It's the warning signs. How do I know I'm headed towards a crisis?
Okay. All right.
Right? Once I have identified, hey, I need my plan, I pull it out, and everything else I just follow. Wow. So the warning signs is the first step. Those are really tangible warning signs. Things like I start crying, or I start withdrawing or isolating. I'm finding myself a lot angrier than usual.
Okay.
I'm either sleeping too much or too little. I'm eating too much or too little. Whatever those warning signs for you are, that's the first step.
Okay.
Right? How do I know it? I need to use my plan.
Okay.
Then the very next step is what can I now do about it? Okay, I'm starting to experience these symptoms that are distressing.
Yes.
What can I do right now to cope? Okay. And we want to identify things that they can do that don't involve reaching out to others. Okay?
Oh, okay. So self. Yeah.
Right. So management strategies, right? So I think I was telling you the other day, I work with Dr. Lily Brown, who's a sleep and suicide researcher at the University of Pennsylvania, and she has really intriguing research that shows that people around 2 to 4 a.m. middle of the night, when no one's around, that's when thoughts of suicide, that's when desires or urges to attempt increase. If anyone's ever worked in an ER or those kinds of settings,
absolutely.
You like, duh, right? This is obvious, right? But we really now have research that shows that. This is why it's so important to prioritize that self-management component. That's not a time when I'm certainly not available most of the time. That's not even really a time when family or friends are awake, able to engage. So if we really want to start helping that individual who's in that crisis, struggling, we need to be teaching them these skills that they can do on their own, right? And it's simple skills. Again, this isn't resolving the crisis. This is helping them manage the crisis. So it's things like distraction techniques, like going for a walk, reading a book, listening to music, right? Exercise is a great one.
Oh, that's true, particularly military. Yes, for sure.
Right. And, if it's too dark outside or too cold, doing yoga inside or something like that, right? So it's simple strategies. Again, the crisis response plan isn't necessarily therapy. It's a life-saving intervention to keep you alive long enough to get to therapy if that's indicated or if that's needed.
Gotcha.
Okay? The next thing continues with things that they can do on their own. So it's reasons for living. That's what goes next on that card.
Okay.
We were sort of the first team to highlight and put that on a crisis response plan. So often people who are struggling with suicide are so focused on wanting to die to resolve the pain and suffering that they're in.
Or the burden that they feel.
The burden that they feel.
Yes.
They've forgotten what makes their life worth living.
Yeah.
And so it's this 180 pivot to sort of help them see, oh, I've got these other things, right? And for this to really work, you provide the space for them to come up with what these items are, right? It's not effective to say, you've got so much to live for.
Right.
That falls dead.
Exactly.
Right? Right?
Deaf ears.
You don't want to be a cheerleader in that moment, right? You
That's
want to be a
very
listener,
true.
right?
Right.
What about your life right now makes it worth living, right?
Okay.
Asking those prompting questions to help them start to think, what is there in my life, right? Whatever that is, we want that to sort of be in the way, right, of them killing themselves. It's kind of a stark way of talking about it, but that's the idea.
Right, exactly.
It's that they read, and often it's, family, friends, spouses, kids,
Career.
write their names right there on the card, right?
Yeah.
Things I want to accomplish, graduate, boot camp, college, walk my daughter down the aisle, right? Take that family vacation we haven't taken. It's one of my favorite moments in these interactions because you see the shift start to take place.
Okay.
You see the I do have these things, right? That I would miss out on if I were to end my life right now.
Okay.
Right? The next step, now this is where we start to engage others.
Okay.
Okay, so step 4 is reaching out to family and friends. And we want to be strategic about this, right?
Right.
So if the recent breakup is the reason why
you do not
I was
there?
suicidal, maybe calling my girlfriend is not the right person for this card, right?
Yeah, right.
So we want to think, who on my card, or who's the right person? Doesn't mean that maybe we'll get back together someday. Who knows?
Right.
But that's just not the name for this part.
Right.
So we want to think
very smart.
We want to think really carefully about who can I reach out to in a time of crisis, and it could be just to hang out with. Let's go grab a bite to eat. Or maybe it's a neighbor I just go talk about the weather in my front yard.
Yeah.
Right?
Yeah.
It doesn't necessarily have to be someone who I disclose, hey, I'm having suicidal thoughts.
Right. Exactly. Right. Just get grounded again.
Just not be alone.
Yeah.
Right? Be distracted again.
Yeah.
And conversely, it could be someone that you disclose that with, right? Maybe you have a long-time high school buddy. You call and say, hey, I'm not doing well. And they get it. They know exactly. Or it's a fellow veteran that was maybe from your unit. That's the right person. Maybe they get it. They're not going to necessarily freak out when they hear you're struggling with this. They're sort of in the know. Those are the perfect people to sort of stick on this card.
Very
and you
good.
want to get their name and phone number.
Oh, so it's right there.
It's right there. You have no idea how many Marines I've worked with. For some reason, their phone's not functioning because maybe they chucked it across the room or whatnot. You never know.
True.
So have that, name, phone number,
right there,
so they could borrow a phone, call,
exactly,
whatever they need to. And then that last is sort of the safety net. That's the professional services.
Okay.
Right. So if they have a doctor, a physician, a mental health provider, that can go there.
Yeah.
But at a minimum, it's the national crisis line. So 988 is the national one for the United States.
Right.
But they can also go to their local ER if they know where that's at.
Right.
Call 911. And there's many other resources that can go there. But that's sort of your 24/7 crisis hotlines is that last step.
And this amazing plan, and I've got to say, I found it amazing because I've been, again, on the end of those calls, and the first call I got, I'm thinking, I never know what to do with that in medical school. Yeah. Why would I know now?
No, we are terrible at teaching providers, right? we really are.
I was really
we're getting better at it.
No, you really are, and I think I want the audience to know about the generosity of your particular group, the Dr. Bryant and his group. You, Dr. Cosm. I mean, when I called, I never get people saying, "Let me see when I can rearrange my schedule." I mean, that was amazing, and I took this course on the USAA / Elizabeth Dole collaboration Face the Fight. And it was eye-opening to me. And what I was happy about, I go, okay, I kind of learned that by default. I learned that one by default, too.
Just from you calling and being on the receiving end of those calls.
Exactly, being on the receiving end. So I could really see where that works. And the reason why I think that's so important is because here I was. I mean, I'd been a physician for years, albeit in rehabilitation medicine. But when we're dealing with rehabilitation, we're dealing with somebody who was walking until the moment they weren't,
Sure.
or was thinking into it. So we were used to them having a crisis somewhere, before they came to us. But this was just so amazing to me, the weight on my shoulders, thinking, what do I do here when this plan makes it all so much easier to do that? And what I'm saying is the person who gets really nervous about being the person who is called, it gives them something to go with, and I want to kind of calm them down. One of my favorite, actually the gentleman who is in command of the Pacific Fleet gave a talk to us in February of last year, and he said, that's your privilege to be on that call. Don't waste it. I mean, he was just amazing. He had just recently been on the receiving end of a call and had dealt with that. So he was speaking from both sides.
That's really where the idea of our peer study came from, is we already know service members and veterans reach out to people.
Yes. Yeah. Right. Okay. Right.
And so we wanted to find who are those people in the respective units that are the people that they gravitate towards. And then let's train them in this really specific intervention so that they know what to do when they're called. Yeah. And that's really, it was simple in design. That's it. That's it, right? And we really saw them. It was so cool was how early on they were able to apply this intervention that then completely thwarted, even going close to this.
Yeah, to that pinnacle, precipice.
Before it became a suicidal thought. Yeah.
Yes, right, exactly. I just find this so amazing, and I'd love you to share with the audience what you share with me about your, we talk about the acronyms that are the crisis response plan, versus.
Yeah, so again, we really wanted to take this mental health, this intervention designed for the mental health space and say, no, there's lots of people who can probably be trained to do this. So we looked at the Heart Association and equated this, and it's just so happened that the letters are the same, just slightly out of the different order. Right. So a lot of the, people listening here are not probably cardiologists, but a lot of them are probably trained in CPR or, basic life support, right? And so the idea is that you administer CPR, you do those chest compressions to keep them alive long enough while you're getting them to the ED or the ER. Right. That's, again, now that more treatment is going to take place. Right. The same thing with the CRP, the Crisis Response Plan, right? You don't have to be a mental health provider to listen to your friend tell you their story, walk them through these steps to help administer this life-saving intervention. Again, to help them through that suicidal crisis so they're alive long enough to get to a mental health provider. We are different than, there's sort of in the field, they're called gatekeeper trainings. They often are, they're helpful, but they're limited, right? So that's basic training in how to identify someone who's struggling with suicide and then referring out. Right. The difference is that there's no treatment provided. Gotcha. Right. Yes. And that's really the distinguishing difference, right? So why would we not equip those people when they're there in that moment to administer something to start easing the pain? Right? And that's the goal of the crisis response plan.
And I thought that was amazing when you were explaining that, because I was a little kid when CPR first came out, okay? And I remember, here we are, we're out at the fair, the Canfield Fair, the biggest fair, in my hometown, and there's little kids that were pumping chests and stuff. That's a lot more invasive than tell me your story. Right. Who would you like to call? You called me, okay, what is it? I mean, and yet we did that with the community. So you're taking this out to the community, I think, is going to, given where we are right now with the chaos in everybody's brains and the chaos in the world kind of reflecting it all, this is a life-saving.
That's our hope.
Much simpler. I mean, in terms of hands-on, and you don't have to
likely
take the pulse and do this.
Too.
And I mean, it really was amazing. When you brought that up, I thought that was really interesting, because when I first took this class, I just took the CPR. No, wait a minute. The CRP class. Yeah, the CRP.
No,
class.
And the Heart Association has done a really good job campaigning.
Yes, haven't they?
Right. And so we are looking to our medical peers to follow that lead. Yes. And really elevate. Again, making it not just a mental health problem, but it's an all of us problem. Right. And we can all take part.
Exactly. And I think that that's going to be something that we hope to do with this podcast, with our social media reach, with your social media reach at The Ohio State University and now, University of Vermont, University of Utah. Where did you go to school in Southern California?
So my undergrad was University of California, San Diego.
San Diego.
Loved
okay.
it. Best.
UCSD.
There's maybe a few beaches that are universities closer to beaches, but mine was pretty close, and I loved it.
Exactly. I have to tell you a story. I mean, I have to tell the audience a story because this is just an amazing connection. So the audience knows they've heard different things that I share about my brain injury. That I became aphasic, and for somebody like me, I really, I read about it. That was for much older people with major strokes. You know what I mean? Right. I had a klutzy, stupid injury with Christmas decorations. Okay. I was trying to learn how to speak again, and God bless Steve Jobs and my Mac computer that I just kept going over and over and over. The Gettysburg Address, the one thing I could remember. Yes. The Gettysburg, 407 years, over and over. Okay. But I couldn't really speak conversational, and I stuttered. Yeah. I mean, I had a whole bunch of stuff. This is over 6 months. So I'm trying to think, where can I learn how to speak again? I went to the University of California, San Diego night class in how to write a screenplay. All right, true story. Because it's all, the movement is in the characters, but the speech is what you have to know. So for 9 weeks, I would get on the plane here, first thing Wednesday morning, fly to San Diego, check into a hotel, get 3 hours of sleep, go to my class from 6 to 9, get the red eye, come back, and somewhere around noon wake up, even though I've been seeing patients since 9. You know what I mean? Yeah. Do that. And that's how I got my speech pattern back at UCSD. I find them to be one of the most incredible universities and kind of quiet universities.
They don't have a football team.
Yeah, right, exactly. Swim team, yes. Basketball, yes.
Surfing team, yeah.
Right, exactly.
So you don't know this, but it's like we were predestined to meet because I actually, when I was at an undergrad in UC San Diego, I worked in an aphasia lab studying people who had experienced strokes. Yeah.
Oh, well.
And they are preeminent at that.
Yeah. They were absolutely wonderful. And then I got a great relationship with the VA there. Their VA
is
also
shared
just
campus. Yeah.
Unbelievable. And what they did when the Gulf War syndrome and ALS and what they were front runners with that. So now I see all of this forward thinking.
Yeah.
It is. Well, more Nobel Prize winners on Nobel Drive.
Yeah, that's an impressive school. Yeah.
It really is. I keep saying when I get really old, that's where I'm going to have to go.
I would love to retire in San Diego.
Yeah. It was, but that's very interesting. And for those of you who like to read and catch up, read some of the things that have been done by UCSD. That was a very amazing thing, and nobody there questioned why I was there, even though I still couldn't explain very well what I was doing there. At the end, though, I will tell you, we wrote a screenplay in 9 weeks, and at the end, the teacher handed me a, she says, "You're a producer, not a writer." Thank you. Hence the podcast.
Well, we all need those people in our lives, right?
Exactly.
To steer us where we should be.
Yeah. For sure. Well, what I would like to ask you is, so you've done this now, you're the person who's got the call, you're talking to the person. What kind of follow-up? We were talking about the fact that on our holidays, 3-day holidays, like we getting through Thanksgiving is a Thursday, Friday, Saturday, Sunday, that there's not.
Be a long time, yeah.
It is a long time. Does the person who receives the call or the person, who actually gets in with this do they follow up? What do you suggest? Do you have anywhere on that card like a follow-up visit between that time and the time they can get into a mental health or brain health provider?
Yeah, I think it's important for me to say that the responsibility of keeping that person alive resides with the individual.
Right,
it's
gotcha.
Not you as the listener.
Perfect.
Right?
Yes, right.
And that is actually true for us as providers.
Truly.
Right. There's, again, if someone is intent on taking their lives, there's often little we can do to intervene. Right. And we have these life-saving interventions that should these individuals choose to use are likely to lead to a significant reduction in attempts.
Perfect,
right. So it's one of those both and situations, but I want to make sure we're not causing
very important.
Guilt,
that's exactly what I want. Exactly.
Right?
Don't throw it on the person, you know. And with the card and having that, and I do believe when you were talking about the person who is in crisis, you may get a life saved. The person who answers may get a life affirmed.
Sure.
So tell me a little bit about that give and take too.
I think a lot of people struggling feel like they're going to burden their friend. But in reality, what actually happens is often the relationship only strengthens, right?
Gotcha,
and I would encourage both sides on that, right?
Right.
Like be present to be the listener.
Right.
And if you are the person struggling, be brave and talk to somebody, reach out, right? Because you may have assumptions of how it's going to go. And I would bet money on it. It's not going to go that way. It's only going to strengthen that relationship. And if you think about it, if you flip it and your good friend comes to you and trusts you with this kind of information, how would you respond? Right? You would feel honored, right?
Exactly.
That they chose you to disclose this. You wouldn't feel put off by it.
Right.
You wouldn't feel like they were burdening you. Right. You would be like, wow, thank you for trusting me. How can I now help? Right? And so a lot of times these assumptions that prevent us from reaching out or get in the way of reaching out are these beliefs that aren't probably grounded in reality, aren't true, right?
Exactly.
And so it's often beneficial to obviously the person we're trying to help, but also the person listening. It feels good to be able to help others, right? And as far as continuing to check in, again, they have their card.
Right,
They can use it, right? And I think it's fine to say, hey, I'm going to call you the next couple of days and just see how's it going.
Or that text that you were talking about.
Or I can just say, hey, have you had to use your CRP?
Yeah.
How's it going?
Yeah.
Right?
Yeah.
Simple kind of check-ins, I think, is sufficient.
Right.
Right? We all have busy lives, right? And this isn't a thing that takes so much time to sort of follow through on.
Right. Very good. So we got this holiday. Then if things get dicey again, we have the 988 number.
Right. You can always reach out for professional help.
Emergency rooms. We've got emergency clinics, all of those as well. And we'll be putting whatever, on our website. When this goes up, there will be all of those resources available as well. What other things would you like to tell our audience today?
Yeah, I also think it's okay to, if it does feel when you're having these conversations, like we're well beyond your capabilities, that it's okay to call together with the person that you have on the phone, right? Don't hang up, like call it with them, reach out, hey, let's walk. I'll drive you to the ED, right? So you don't have, even as the helper, figure this out on your own, right?
Gotcha, right.
You can call the crisis line together. You can take them to the ED, reach out for support. Don't feel like you have to be the one that makes the call of whether this person is truly safe or not.
Very good. What other words of wisdom would you like to share with all of us today? We hope to have you back. First of all, I'm not sure. We really do, because I do see you as being a leader of the generation that I'm talking with, that I'm dealing with right now. And so many of the young people in our nation, like you said, the second major cause of, I would imagine the first cause of death is it's still accidents, like it was before that. And what I was thinking of, the irony of that is many times the suicide may be result of an accident, a loss of ability, that injury for that, for sure. So what other things would you like to kind of help us with for today with your crisis response plan?
Yeah, I mean, know that that's one of our interventions, but we have more in-depth treatment should that also be needed.
Okay.
Right? And so we have the crisis response plan, but maybe in another podcast I can come talk about our full treatment, but I can briefly talk about it here. It's a 12-session model where we sort of dive into the understanding the crisis and what skill deficiencies there were to sort of shore up, right?
Okay.
So that these underlying core vulnerabilities of that emotional dysregulation and cognitive inflexibility sort of become resolved. And so when you do have crises, again, I wish I could just ensure no one experiences crises, but we can't do that. Right. So when you do experience a crisis, you're prepared. And that's really the crux of our treatment model. And you can almost think of it like the CRP on steroids, right?
I gotcha. Okay, that's a good way to think of it, right?
But weekly reminders, again, this would be with a licensed provider. Right. The other thing I'll say is podcasts like this are great to get the word out, but we're also developing online resources and trainings that people can take. So to get in-depth training on administering the crisis response plan.
That is.
And you'll be able to log in to the website, take the course, and then now you're equipped to do this. And we're not just targeting mental health providers with this.
Okay.
We are trying to, again, get as many people who should be trained in this trained so that there are lots of people available to whoever that suicidal individual is to know to reach out to.
I really like that. I kind of think of the heart and soul. You know, you got CPR for the heart, and then the soul, you know, the actual human part, you know, in there. That's very interesting. Do you have any research available now for veterans, or is there anything that's going to be in the future that we could have our veterans check back and see? I know so many of them say, Doc, I just wish if somebody wants to take a look at my brain, they can do whatever. Very, very anxious to help out. You know, that's kind of what our military and our guardians do, right?
Yeah, I can talk about research ad nauseum, so cut me off when you feel like I need to. But so crisis response plan was designed and first tested with active duty soldiers. So it's a treatment for soldiers, for current service members, right? And in that original trial, which completed around 2015, published 2017, we show that if you get this intervention, the crisis response plan, you are 76% less likely to have another suicide attempt.
That's
right?
a huge, yes.
Just one 30-minute visit, right? Again, we did test this in a hospital, right? setting, so in an ED, in an outpatient setting.
Okay.
We've had subsequent trials where we've added this intervention to treatments.
Okay.
So a lot of mental health providers will say, hey, I can't do this PTSD treatment. I can't do this depression treatment because this person is suicidal. Right?
I see.
And that doesn't sit well with us. Like, why would we create a barrier to someone who needs the care? And so we show that you can treat PTSD and suicide risk simultaneously. And again, those that got that crisis response plan demonstrated faster reductions in both ideation and attempts compared to like the standard of care at the time.
Okay.
So you could, again, a lot of veterans have both. People are complex. They don't experience disorders one at a time, right? And so we have to think strategically about our models. How can we target the actual person and what they're dealing with, right? We've had other studies that have looked at crisis response plan delivered via telehealth. So a lot of mental health shifted, during
the pandemic,
COVID. And suddenly a lot of people who, because suicide risk was a rule out. That was considered someone who's not appropriate for telehealth. And so all of a sudden the people who needed the care the most were without options. Again, that we didn't like that, right? No, you can do this effectively and safely. So we've had a few different trials. We had a trial that's just crisis response plan. Again, showed that collaborative nature of the CRP, again, reduced the risk for individuals. And then we had our full treatment model testing telehealth for BCT that I led, again, showed those who enrolled in BCT, which uses the crisis response plan every session, showed a decrease in recurrence of frequent suicide attempts, right? So the frequency of how often they attempted reduced compared to the other treatment we were testing.
Again, those
are
lots
huge of lots of studies that show in randomized controlled trials, again, the gold standard approach to saying, do these behavioral interventions actually lead to change? All come out with CRP sort of at the forefront. At the lead. Yeah.
So for next year, when we bring the Ohio State University back, we'll say, like, if there are different studies that you need veterans or something, let us know, or we'll put it up on the website and see. So if they are willing to come, which they would be.
I mean, if they want to go to our website, S.T.R.I.V.E, so S.T.R.I.V.E, the number 2, and then B.E. dot, I believe, org. There's a participate in our research button.
Perfect.
They can fill out right now.
Perfect.
And they can fill out a survey, and it just lets us know that they're willing to participate. And then we match them with current studies that are ongoing. Right?
Perfect.
Which we currently have some. We sort of always have treatment studies ongoing. And then we have some other easier, more survey-based studies.
Perfect.
So we have a mix. But that's our registry, just so people can come and say, hey, I'm willing to help you guys know how to better help us. And we specifically want veterans and active duty service members. But we'll take anybody struggling with trauma, and that's an adult. 18 and older.
Right. And you want to tell us what STRIVE stands for? Because it's a mouthful.
It's
I have
lot.
it written down.
Yeah.
But
It's a suicide and trauma reduction initiative.
Okay, gotcha.
Okay, so just suicide and trauma reduction is how you want to think of it.
Okay.
And then initiative is the IVE.
I gotcha.
Yeah.
All right, very good. And you're the director. Well, I'll tell you, this has been just a wonderful coming together, and I think a very good message for ending one year and going into the next. I
Yeah.
mean, this is an ongoing, infinity type message. Take care
Yeah.
of each other, that sort of thing. But I would like you to finish off our podcast today with one of your best quotes. And I know it's rather long. But,
I'll
I'm
go ahead and read it.
Okay, that would sound great. Anything else before you do your sign off that you want to mention to the folks?
Yeah, again, STRIVE exists to really understand what is getting in the way of veterans' recovery in areas of suicide and trauma.
Oh, okay.
So we're very much a research lab and a clinical treatment as well. And so that's sort of our mission. And along with that mission, this quote is sort of one of our guiding principles, and it's actually a quote by Abraham Lincoln.
Oh, wow.
And it's actually used in a lot of, you'll see it like if you walk the halls of Veteran Affairs hospitals, okay? What's cool about it is he, foreshadowed the existence of STRIVE because he uses that word STRIVE.
He does.
In the quote.
Okay.
So we like the quote, and it's cool because he uses the word STRIVE.
Exactly.
So,
well, we've already talked about the Gettysburg Address. Abraham
right.
Lincoln's big on, and talk about a person who died of head trauma.
Right.
We're talking. So, Abe, thank you so much.
That's right. So I'll read that now for us. So, with malice toward none, with charity for all, with firmness in the right as God gives us to see the right, let us strive on to finish the work we are in, to bind up the nation's wounds, to care for him who shall have borne the battle, and for his widow and his orphan, to do all which may achieve and cherish a just and lasting peace among ourselves and with all nations.
Oh, he's one of my favorite people in all of history, and you're one of my favorite people on the planet right now.
I appreciate
I'm telling
that.
you, for sure. We really appreciate your being here. Everybody kind of think of that. Think of this during the holiday time. Strive, strive to thrive. I mean, I think that between the Dr. Kazim, who came to us in November, and Dr. Baker, who's here with us at Christmas time, I think that we can really make some great headway in our families, in our communities, in our nation, and we needed it, all three of those. So I want to thank you so much for being with us for the 2025. We were striving to be better in 25, strive to be alive in 25 was our motto. So I think for 26 it's going to be, let's see what we can fix in 26. So think about that, and we'll see you in January. Thank you so much.
If you are thinking about harming yourself or attempting suicide, tell someone who can help right away. Call 911 for emergency services. Go to the nearest hospital emergency room. Call or text 988 to connect with the 988 Suicide and Crisis Lifeline. This podcast is made possible thanks to a grant from the Fred and June McMurray Foundation, and it's produced by the Resurrecting Lives Foundation at the Sycamore Studio. Music is written, performed, and graciously provided by Tim Beckley. Remember, when you work toward brain injury recovery, it is best to journey with a friend and keep your gait steady and your spirit strong. Finally, always seek shelter from your storm.
Baghdad, the Basra, the Boston, the Bakersfield, the hottest battle I ever fought is raging inside of me. My brain has been battered, scrambled and rattled, and no one knows what's going on.